Cannabinoids are some of the natural components found in the cannabis sativa plant. The most common active ingredient is delta-9 tetrahydrocannabinol, also known as THC, which produces the psychoactive effects of cannabis. Other cannabinoids include cannabigerols, cannabichromines, tetrahydrocannabinols, cannabinol, and cannabidiol. Cannabis has been used for medicinal purposes for over 3,000 years, and it is now widely accepted that the cannabinoid receptor agonists have antinociceptive and antihyperalgesic effects at spinal and supraspinal levels seen in chronic and acute pain models. Although marijuana is the source of the aforementioned, as well as a multitude of other cannabinoids, our bodies have their own endogenous sources that include anandamide and 2-arachidonoglycerol, or 2-AG. These endocannabinoids are neuromodulators and are involved in the maintenance of homeostasis, including pain management. They stimulate the spinal column in response to noxious stimuli responses, stopping processing of the noxious stimuli, and inducing analgesia. All cannabinoids affect specific receptors located within the central and peripheral nervous systems identified as the CB1 and CB2 receptors. Binding of agonists to these receptors modulates nociceptive thresholds via the regulation of neuronal activity as well as through actions on non-neuronal tissues. Activation of both G protein-coupled cannabinoid receptor subtypes causes the inhibition of adenyl cyclase, decrease of calcium conductance, and increase in potassium conductance that are linked to suppression of neuronal excitability and neurotransmitter release. Cannabinoids taken with the aim of pain management, as cannabis often is, bind to the CB1 receptor presynaptically, inhibiting glutamate release, with THC decreasing NMDA response by approximately 30 to 40%. This interrupts synaptic transmission in several central nervous system regions, such as the amygdala, periaqueductal grey matter, or PAG, rostral ventromedial medulla, and superficial dorsal horn, all associated with nociceptive signaling. CB2 receptors have been linked specifically in the management of inflammatory pain and are found on mast cells where they inhibit the release of pro-inflammatory factors near nociceptive nerve terminals and neutrophil accumulation, both known to generate inflammatory hypergesia. Now, there is a rising interest in delta-9 tetrahydrocannabinol as well as other synthetic cannabinoid derivatives in terms of their ability to increase the effectiveness of other analgesic drugs. This phenomenon has been demonstrated with non-steroidal anti-inflammatory drugs, or NSAIDs, alpha-2 adreno and mu-opioid receptor agonists, that in combination with the cannabinoid receptor agonists have been shown to have synergistic and additive interactions attributable to a number of similarities between their systems. Alpha-2 adreno and mu-opioid receptors are also G protein coupled, sharing a number of signal transduction pathways with cannabinoid receptors. All these receptors are similarly located in the PAG and substantia gelatinosa, which are all heavily involved in antinociception. Furthermore, these receptors are thought to exist on the same neuron, hence sharing a common G protein pool that may lead to interreceptor signaling where activation of one will increase the signaling in the other receptor. Cannabinoid agonists are also shown to have an effect on endogenous opioids by increasing their synthesis and release. Finally, interactions between prostaglandin inhibitors like NSAIDs and cannabinoid agonists have also been demonstrated. This is attributed to the similarity in structure of endogenous cannabinoid agonists and prostaglandins, as well as similar on converging transduction signaling between the two. NSAIDs such as indomethacin and fluoribuprofen have been shown to enhance CB1 receptor activity, where CB1 receptor antagonists such as AM251 block NSAID-induced antinociception in inflammatory pain models, while CB1 knockout mice show decreased indomethacin efficacy. A supportive mechanism is found in the inhibition of fatty acid amide hydroxylase, or FAAH, which is a serine hydrolase that breaks down cannabinoids, as well as COX-2, otherwise known as cyclooxygenase 2, an enzyme that facilitates the inflammatory response proposed to metabolize endocannabinoids such as anandamide and 2-AG. Hence, administration of a COX-2 inhibiting NSAID would prevent anandamide breakdown, increasing its concentration and enhancing its analgesic effects. Overall, Preclinical and clinical studies in this area indicate that these findings may have a significant impact on the treatment of a diverse number of diseases with chronic and acute pain in terms of dose and receptor agonist selection to improve therapeutic management with minimal side effects.